Live.
Okay, so good evening everyone and namaskar. So I would today we will uh, it is a great pleasure to invite you all Oncology Symposium 2024. So I would like to invite Dr. Sumit Goyal sir for the welcome note. So he's a senior consultant, Department of Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi. So it's over to you, sir.
Thank you very much. I think it's a great debate. And lung cancer, the more we talk, we keep on learning more. And every time we discuss lung cancer, there's one or other point which we capture, and it is ever changing. So, in continuation of the same and some discussion on the lung cancer, we have very eminent speakers today. Following Jyoti. She's a consultant medical oncologist. She's working at Mechanics watching the lung cancer. Followed by we have Dr. Rajiv Vachin, again, medical oncologist at the same hospital, Mechanics watching consultant. We have Dr. Chandrani Malade, again, a medical oncologist from Kolkata. So we will be looking at different aspects of lung cancer. So to start the talk, we have Dr. Padani Basu. She will be speaking on molecular biomarker testing. So over to you, Dr. Padani. For you.
Thank you, sir. Um, First of all, thank you, sir, for giving me this opportunity. Uh, can anyone please share the slide?
Yes, ma'am.
So today I'm going to talk regarding the molecular biomarker testing in the lung cancer. Next slide. So first we are going to talk regarding the incidence rate, the mortality rate of lung cancer in India, the recent Globocon 2020 data, what biomarker test we usually do in our daily practice, and recently what the new molecular test means the evolution of biomarker test in NSCLC. Next slide. So, first of all, the incidence data, the number of new cancer rate in lung cancer. So, this is the recent Globocon 2020 data. If we consider the incidence of lung cancer, there is most common cancer in India is breast, followed by lip or oral cavity cancer, followed by cervical CA, and then lung cancer. So, the incidence is around 5.5%. And if we consider, next slide. So we can say that it's the second most common cancer for male in India. And now coming to the death, if we consider the death rate, we can see that lung is the fourth most common cancer related death. And if we consider the 5-year prevalence rate, which is around 5.86%. So we can say the burden of lung cancer in India is very high, and most of the patients present in a very advanced stage. Next slide. So whenever a lung cancer patient comes to our OPD, we usually do the staging workup, and we found that most of the patient present in a stage 4 lung cancer. And nowadays we have options of more driver mutation in stage 4 lung cancer as well as in early stage lung cancer. So 50% of the patient with advanced non-squamous as well as squamous histology have a driver mutation, and we have lots of drugs. Whenever there is EGFR mutation, we know that the most common mutation is KRAS mutation, which is around 25%, followed by EGFR mutation, which is around 23%. And there are several drugs like first generation anti-EGFR TKI, like we have options of arlotinib, geftinib. We have second generation anti-EGFR TKI like dacomatinib or afatinib, and in third generation TKI, we have options of osimertinib. For exon 20 insertion, we have options of amivantamab and we have options of mobocertinib. There are other mutation like ALK. The percentage is low, around 7%. We have options of crizotinib, alectinib, ceritinib, and lorlatinib. We have KRAS mutation. As I have already mentioned, the percentage of KRAS positivity rate is much more high, which is around 25%, and we have options of sotorasib for KRAS mutation. Other rare mutation like mate exon 14 skipping mutation, we have options of capmatinib drug or tepotinib drug. We have HER2 positive like trastuzumab deruxtecan. For NTRK mutation positive, we have options of larotrectinib or entrectinib. When there is BRAF V600E mutation positive, the incidence is pretty low, around 2%. We have options of dabrafenib. For RET fusion, we have options of selpercatinib, pralsetinib. And for ROS1 mutation, we have options of crizotinib and entrectinib. So these are the all the and targeted therapy those we have for lung cancer patient. And we found that the 50% of the patient with non-squamous histology have this driver mutation positive. Next slide. So now coming to the importance of this biomarker testing in non-small cell lung cancer, there are several studies which showed that whenever we are using this targetable agent, uh, rather than using chemotherapy, there is a clear separation of these two Kaplan-Meier curve, and we can say that there is median overall survival is around 18.6 months whenever we are using this particular targeted therapy, versus whenever we are using non-targeted therapy like chemotherapy, the median overall survival is very low, which is around 11.4 months. So around 7 month benefit whenever we are using this targetable agent. Next slide. So now coming to the NCCN or our recent ASCO-ESMO guideline. Generally for a lung cancer patient, for adenocarcinoma patients, as well as for squamous cell carcinoma patients also, we are doing this EGFR, ALK, ROS, BRAF mutation test, mate exon 14 skipping mutation, RET fusion genes, NTRK, KRAS mutation, even HER2 testing, and along with PDL1 testing. Next slide. So now coming to the methods of tissue testing in NSCLC, we have options of IHC, we have options of FISH, we have options of NGS, which is a broad spectrum test. We have options of PCR test, which is either DNA sequencing PCR test. We have options of RNA sequencing panel also. So whenever we are using this DNA sequencing in NGS or PCR, it usually detects insertion or sometimes it detects point mutation or deletion. So it detects EGFR, KRAS, BRAF, HER2, and mostly mate exon 14 skipping mutation. For IHC, we can detect ALK, ROS, and the major advantage of this IHC is it's a very easy test. It requires less time, and it also detects the PDL1 also. For FISH, whenever we do FISH can detect ALK, ROS. Obviously, it's a very highly specialized method. Next slide. So we can say that these are the methods of tissue testing. One is NGS, one is PCR based, one is FISH or IHC. Now coming to the evolution of biomarker test in NSCLC. Next slide. So what we usually do? We usually do from means either we do this sort of biopsy from AFP block, or we sometimes use this ascitic fluid cytology, or sometimes presents with massive pleural effusion. So we usually do pleural fluid cytology or ascitic fluid cytology, and from then if there is any malignant cell, then we prepare the cell block, and from this block we usually do this sort of testing, either by DNA based test or RNA based test, or we do sometimes we do IHC or FISH test. Next slide. So we can say that these tests are very much required. Sometimes even we do liquid biopsy because of whenever there is inadequate sample or the location is means very difficult to approach for tissue biopsy. In that case also we do liquid biopsy. So it's an option. From liquid biopsy also we can get this EGFR, cross, BRAF P600, ENTRK, MET, exon 14 skipping mutation also. And for all NSCLC patients, we do this broad spectrum, this 12, at least this 12 gene panel test along with this PDL1. Next slide. Now coming to the ctDNA testing methods, yes, we can say that ctDNA testing may never replace the tissue biopsy entirely, but we can say that it could have a complementary role to support treatment selection in patients with NSCLC. Why? Because sometimes it can help in diagnosis and treatment selection also, and it also help to monitoring the prognosis. We can assess the treatment response also, because there are several studies which showed that if there is persistent ctDNA positive, then there is more chances of relapse rate. So we can say that ctDNA has several potential application to predict or monitor the clinical progression or recurrence in both early stage as well as in advanced stage NSCLs. Next slide. So there is a tracer study where they found that whenever there is ctDNA positivity, they did some ctDNA profiling, and they found that 93% of the patients with disease recurrence were MRD positive. So whenever there is MRD positive, we can say that relapse rate is much more high. And whenever there is MRD negative, 90% of the patient without recurrence were MRD negative. So we can say that if there is ctDNA positive, so we can say there is more chances of relapse rate. And if it is ctDNA negative, then there is less chances of recurrence rate. So in the tracer study, ctDNA profiling was able to confirm the MRD negativity, and it detects MRD in patients who relapsed before their disease was picked up by standard imaging. So, through ctDNA, we can detect or we can detect the disease in a early stage. That is the main advantage of the ctDNA testing. Next slide. Now coming to the basic difference between tissue biopsy and liquid biopsy. Obviously, tissue biopsy is an invasive procedure, whereas in liquid biopsy, it's entirely a non-invasive procedure. We only require some 10 ml of whole blood. And whenever repeat sampling, which is very much difficult for tumor tissue, because whenever there is disease progression or we did rebiopsy, sometimes there are inadequate sampling or there were insufficient tissue material. So in that case also liquid biopsy is very helpful. And sometimes we have tumor heterogeneity. In that case also liquid biopsy is very much helpful. Now coming to the TAT, if we consider the TAT timing also for liquid biopsy, around 14 days we found the reports. Next slide. Yes, these are the multiple genes involved in NSCLC. As I have already mentioned that usually we do the single gene testing, or sometimes when there is no financial issue, we usually use this broad spectrum NGS test. And we usually check if there is in EGFR, ALK, TOS, is any actionable mutation is positive or not. If there is any positive mutation, we can start this particular these anti-EGFR drugs or anti-ALK regime. Next slide. Now coming to the advantage of NGS, as I have already mentioned, we have options of FISH, we have options of PCR, we have options of IHC, we have options of NGS. Now coming to the advantage of NGS over this PCR technique or over this FISH or IHC technique. NGS is one that we can detect more mutation, means as the number of clinically actionable biomarker has increased. So it's a platform where we can detect more mutation alteration in a single platform. Obviously, it is little bit costly. There are certain pros, like it can detect a broad range of molecular alteration in a single sample. It may identify the new marker, which is very rare also, that could offer additional information. And in that case, we can try it can help with the development of new or more effective treatment. But there are certain cons of using this NGS over single gene test. First is it's a highly complex and it requires a little bit time. And the advancement in the field of NGS are evolving rapidly. So patients and the clinical community must receive the sufficient education in this area. These are the cons of using NGS. The major advantage I can say that it can detect a broad range of molecular alteration in a single sample. Next slide. Next slide. So these are the mutation like EGFR, KRAS, MAKE, ALK, and if we consider frequency, we can see there is majority. We have found this KRAS mutation, EGFR frequency is around 30 to 40%. ALK mutation is up to 7%. BRAF, which is very rare, 0.5 to 5%. MATE or rate or NTRK mutation, the frequency is very less than 2%. And we have several platforms like PCR, we have options of FISH. Through FISH, we can detect ALK or ROS. Through IHC, we can detect these PDL1 also. Next slide. Now coming to the EGFR mutation in lung adenocarcinoma. Next slide. So we usually prefer to use this FFP block, and from this block we usually do this sort of testing. Whenever these blocks are not available, sometimes we do cell cytology, and if there is any positive malignant cell, we prepare the cell blocks, and in that case, cell blocks are preferred over smear. And from these cell blocks, we can detect this EGFR. Next slide. Next slide. Now coming to the EGFR test for NSCLC, we usually do EGFR testing for advanced NSCLC, but sometimes in early stage lung cancer also, we do this EGFR testing. If there is EGFR mutation positive, we have options of adjuvant osimertinib data, and through which we can increase the overall response rate also. Next slide. Next slide. So now coming to the ALK rearrangement in NSCLC. Next slide. So for ALK, generally we use these IHC or FISH, but the false positivity rate of 0.1% with 0.1% with FISH. Sometimes we do IHC for ALK testing, which is less expensive. Next slide. Now coming to the Roche rearrangement in NSCLC. Next slide. For Roche also, we sometimes use this FISH technique, or sometimes we use PCR or NGS based test technique. Next slide. Now coming to the KRAS mutation, and we can say that these KRAS mutation are mutually exclusive with EGFR and ALK mutation. And if we see the incidence rate of this KRAS positivity rate, which is around 30% of lung adenocarcinoma, the most common KRAS mutation arise in codon 12 and 13, with the G12C variant found only 13% of the patients with lung adenocarcinoma, and it denote that it has a very poor prognosis. And we have now coming to the platform of we have the method of detection. We have options of this multi-gene NGS panel. For we have options of single gene KRAS 12C gene testing also, but we usually do this NGS platform for this KRAS mutation. And sometimes we use this PCR based technique also. Through PCR also we can detect this KRAS mutation. Now coming to the targeted therapy, we have options of sotorasib, which is currently approved for patients with NSCLC, those have KRAS mutation positive. Next slide. Now coming to the BRAF mutation in NSCLC, the incidence is very low, which is around less than 2%. The BRAF V600E mutation were present in more than 50% of the BRAF mutation cases and is thought to be more prevalent in the smoker group. For EGFR ALK, we usually found for non-smoker population, and for BRAF mutation, we can say that there is more prevalent in smoker group. And non-V600E mutations such as V600K or sometimes G466V, which are less prevalent and occurs in 17% of the patients with BRAF mutation. Overall, the incidence is very low. Up to 5% of the patients with NSCLC have this BRAF mutation positive. And while not widely recommended, we usually do PCR-based technique for BRAF mutation testing, and NGS is generally used for multi-gene test panel. We have targeted therapy for anti-BRAF mutation. We have options of davrafenib, we have options of trametinib. And whenever there is acquired resistance, resistance generally developed by a pathway that bypass the RAF pathways, such as redirection of cell signaling via the downstream pathway like MYC1 or 2 kinase pathway. Next slide. Now coming to the MET exon 14 skipping mutation, which is again very rare. It is around 3 to 4% of non-squamous NSCLC, and if we can see the sarcomatoid cancer, the incidence is much high. It's around 20 to 30% of sarcomatoid cancer. Majority of MET exon 14 skipping mutation can be detected with the DNA NGS, but it increases sensitivity whenever we are using this RNA-based NGS. Next slide. For MET exon 14 skipping mutation, IC is not recommended, FISH is not recommended. We usually do PCR, which is DNA based. Sometimes we use RNA based PCR also. And obviously, NGS is a broad platform where we can detect many mutation in a single, from a single sample. But we can say that RNA NGS is more sensitive for detection of MET exon 14 skipping mutation. Next slide. Now coming to the therapy for MET exon 14 skipping mutation, we have options of capmatinib or tepotinib whenever there is MET exon 14 skipping mutation. Now coming to the RET receptor positivity, RET fusion, we have now first of all coming to the incidence, which is very rare, again around 1 to 2% of non-squamous NSCLC. Yes, for 10 to 20% of papillary thyroid carcinoma have this RET fusion positivity rate. And we usually do for majority of RET fusion can be detected by DNA NGS, but it increased sensitivity with RNA NGS. So we can say for MET exon 14 skipping mutation for RET fusion, we usually prefer to use this RNA based NGS because the sensitivity is much more. Next slide. These are the pros and cons and of IHC, FISH, and DNA NGS. DNA NGS, the major pros, we can say that it can detect simultaneously get mutation information, and the cons is it's a poor coverage of some uh, intronic means some means sometimes the sensitivity is very low, like rate testings for rate fusion testing, we can say that the RNA NGS is more sensitive. Is means it means there is more sensitivity whenever we are using this RNA based NGS. So majority of this rate fusion can be detected with DNA NGS, but it increase sensitivity whenever we are using RNA based NGS. Next slide. Now coming to the NTRK fusion. For NTRK, again the incidence is very low. It's around less than 2%. We have options of IHC, we have options of RNA-based or DNA-based NGS, we have options of FISH, we have options, and again there is certain advantage or disadvantage with each test. And obviously, again, this RNA-based NGS is more sensitive. IHC, yes, obviously, because of fast tag, we are doing sometimes we are using IHC technique for NTRK fusion detection. But we can say if we consider the more sensitive test, it's a RNA based NGS. Next slide. For methods for NTRK fusion detection, I'd say yes, as I have already mentioned, the TAT is very less, so rapid results. It can detect transcribed and translated events only. Cost is very low because it's a single test and it's widely available. The major disadvantage of this IHC is sometimes there are some fusion partner and positive unknown mutation also which cannot be detected by IHC. And the major advantage of NGS is it's a potential for multiplex testing, less depletion of tissue, fusion partner and positions are defined, and obviously DNA based NGS versus RNA based NGS. Whenever we are considering, RNA based NGS are much more sensitive than DNA based NGS. Next slide. Now coming to the HAT2 mutation in NSCLC, we have options of this trastuzumab deruxtecan. The incidence is again very low, only 3 to 5%, mostly exon 20 in frame insertion. And obviously for HAT2 testing, we usually prefer NGS based testing and which is DNA based. Next slide. So these are the molecular biomarker testing. As I have already mentioned, EGFR, ALK, ROS, BRAF V600E, NTRK, rate, MET exon 14, and KRAS G12C mutation. And these are the drugs are available for this particular targetable mutation positivity. Next slide. Now coming to the PDL1 overexpression in NSCLC. Next slide. We usually use this DACO platform for 22C3 antibody clone. Sometimes we use Ventana Pro for SP263 or SP142. So, and there are certain different coding system for DACO 22C3. We have options of PDL1. We have options of whenever there is PDL1 is more than 50%, we have options of single agent immunotherapy. Whenever there is 1 to 50%, we have options of chemoimmunotherapy. For when we use these SP263 or SP142 probes, there are means they are using some tumor proportion score also. So we can say that these are the different antibody clone like 22C3, SP263, SP142, and these are the several different platforms which we use for detection of PDL1 and PDL1 testing. Next slide. Next slide. And obviously there are different scoring system for different platforms. And PD-L1 testing is a very important current biomarker to guide the immunotherapy. If it is more than 50%, sometimes we are giving single agent immunotherapy. When it is between 1 to 50% or less than 1%, in that case, we have options of chemoimmunotherapy. Next slide. Now coming to the conclusion, we can say that for NSCLC, this biomarker testing is very much important because we have more options of this anti-targetable mutation, and ideal TAT is 2 week, and we have options of NGS through which we can detect this actionable mutation. Next slide. And these are the several, as I have already mentioned, these are the several methods which we usually use for detection of the specific mutation. Like EGFR, we have options of PCR, NGS. For BRAF, we have options of PCR, NGS, sometimes IHC also. For KRAS mutation, we have options of PCR and NGS. For ALK, we have options of additional options of FISH along with NGS and IHC. Roche also we have options of fish, NGS and IHC. For rate rearrangement, we again options of fish and NGS. So we can say for through fish, we can detect ALK, Roche and this rate rearrangement. Sometimes we can detect NTRK or MET amplification also. But overall, we can say that the NGS is a platform through which we can detect multiple mutation. So these are the molecular testing which we usually do for lung cancer. Whenever there is a stage 4 lung cancer, we usually do this sort of molecular testings. Next slide. So that's all from my side. With this, I would conclude my talk.
Thank you, Dr. Paulami. That was a wonderful and nice presentation. We all know the lung cancer in earlier days was like a death sentence with metastatic disease, patients surviving less than a year. But the advent of molecular targets and markers and how to do it has made a significant difference in our lives. And again, with the advent of newer technologies and newer targets, we are improving day by day. And thanks for taking us through the molecular markers, that how important are they in our day-to-day practice. And at the same time, few of them are very common, which we should be doing everywhere, wherever we are practicing. And some being the rarer one, we need to do at our discretion, depending upon the patient population that we are seeing. So thank you very much for your nice presentation. I don't think if there are any questions. If there are any questions, we will take it later. So next,
Thank
there
you,
is a
sir.
talk by Dr. Rajiv Lochan Jena. He's a consultant medical oncologist at Netaji Subhash Chandra Bose Cancer Institute, Noida.
Thank you,
So
sir.
Dr. Jena will be
Thank
talking
you.
about advanced EGFR mutated non-small cell lung cancer, evidence-based review of targeted therapies. Over to you, Dr. Rajiv.
Thank you, sir, for this opportunity. And may I ask, yeah, so the slide is there. Yeah. So I will be discussing about advanced EGFR mutated non-small cell lung cancer, which would be a evidence-based review of targeted therapies. Next slide. So coming to the lung cancer epidemiology, globally in 2020, it accounted for, like, lung cancer was the second most common cancer diagnosed in males and third in females. It is number one cause of cancer-related mortality in males and number two in females. In India, the lung cancer is fourth leading cause of cancer-related death in India and fourth overall incidence. Non-small cell lung cancer is the most common type of lung cancer, as we know. Next slide. Now, coming to the relative survival rates, which can vary by stage at diagnosis. Uh, on the left-hand side, we can see the stage-wise incidence rates. In stage 1, it is 1.2%, and it goes on increasing to 66% in stage 4. That is, most of the cancers are diagnosed in more advanced stages, like stage 3 and stage 4, which accounts for almost more than 90% of the cases. Now, coming to the 5-year OS outcomes, which decreases with increasing stage, we can see like in stage 1A1 and 1A2, the OS outcomes in 5 years are 92% and 83% respectively, which goes down as we rise the stage ladder. It is for stage 4A, it is around 10%, and stage 4B, it is 0%. That is, none of the patients survive beyond 5 years in stage 4B. Next slide. Now, more than 50% of stage 4 NSCLC have biomarkers. Here, we would have to see what are the, how we differentiate. There is prognostic biomarkers and predictive biomarkers. So what is prognostic biomarkers? Prognostics biomarkers are indicative of patient survival independent of treatment received, because the biomarker is an indicator of the innate tumor aggressiveness. So, and predictive biomarkers are the one which is related to the treatment. That is an indicative of therapeutic efficacy, because there is an interaction between the biomarker and the therapy on patient outcome. The testing for several genetic mutations and for PDL1 status is recommended for patients with advanced NSCLC to determine whether they can receive treatment with targeted agents. So Dr. Polumi has already mentioned about what analysis we usually do. We have KRAS, EGFR, ALK rearrangements, HER2, BRAF, PI3 KCA, MET amplification, NRAS, MAKE1. And as we know, that KRAS mutations is lead to increased tumor cell proliferation, and it is found in around 25% of the cases. And EGFR mutations, that it is found in 17% of the cases, and the mutations drive tumor growth. So this is a prognostic marker, and also it predicts the response to EGFR TKIs. So it is a predictive marker too. So similarly, EGFR and ALK, these are both prognostic and predictive markers, and KRAS, as we know, is only a prognostic marker. Next. Now coming to the testing methodology for targetable mutations in lung adenocarcinoma, this has been already described by Dr. Polumi. As we can see, EGFR, for EGFR, we do PCR-based testings. For ALK and ROS, the recommended testing is FIS, though it can be detected by IHC, but it is not sufficient to initiate treatment. And for PDL1, we have IHC test. Next. Now coming to the EGFR driver mutations in lung cancer, the most frequent EGFR TKI sensitizing mutations, they occur in exons 19 and 21, the most common being exon 19 deletion and exon 21 L858R mutations. Next. Now coming based on a limited number of studies, the prevalence of EGFR mutations appears broadly similar across disease stages. Overall estimated prevalence in Asian, it is 30-40%, while in Caucasians, it is lower. It is 10-20%. Now, as we can see, the stage-wise prevalence rates in Asia, US, and Europe, we can see that it is the most in Asian population, followed by US, and then the European population. In stage 1, in Asian population, it is around 34-55%, and it ranges from 33-49% in stage 4 population. If EGFR TKIs were available in the resectable setting, a similar proportion of patients may be able to benefit compared to the advanced setting. Next. So this is the NCCN guidelines, where you can see the most commonly described mutations, the EGFR exon 19 deletion and L858R mutation in exon 21 are associated with responsiveness to oral EGFR TKI therapy. Most recent data indicate that tumors that do not harbor a sensitizing EGFR mutation should not be treated with EGFR TKI in any line of therapy. And molecular testing for EGFR mutations should be performed when adjuvant TKI therapy is a consideration for NSCLC stage 1B to 3A and stage 3B, that is in T3 and 2. Next. Now, This diagram very well defines the EGFR activating mutations which result in constant signaling by the EGFR. On the left hand side, we have EGFR wild type, where the pathway is on only when EGF is bound to the receptor, that is the epidermal growth factor is bound to the receptor, while we can see in the EGFR mutated side, the right side, the pathway is on even when the EGF is not bound, that is, it is in on position throughout, and there is downstream activation, and this leads to cell survival, proliferation, protein synthesis, and the cancer grows on. Next. These are the current treatment options for advanced lung cancer. For non-squamous cell, as we first see what driver mutations we have. If it is EGFR mutated, we have first generation, second generation, and third generation TKIs. Third generations are recommended, and nowadays recommended as the standard of treatment, osimertinib. We have ALK and ROS fusions, where in first line we can use crizotinib, and in second, third lines we can go for alectinib or ceritinib or chemo plus ramucirumab. These are the options. And when if no driver mutation is present, we see the PDL1 status. If it is more than 50%, we have option of single agent immunotherapy. Also, for lesser PDL1, we can combine chemo and immunotherapy. Also, chemo plus minus bevacizumab is an option. And we have further, like in second lines, we have options of immunotherapy also. Similarly, for squamous cell cancers, PDL1 status, if it is greater than 50%, we have immunotherapy single agent. And if it is less than 50%, we can go for chemotherapy. And for further lines, we can use immunotherapy. Next. And now we can see the osimertinib, which is a third generation irreversible CNS active EGFR TKI, which is selective for both EGFR mutated and EGFR T790M resistance mutations. So it acts with EGFR mutations, exon 19 L858R mutations. It also acts on the T790M resistance mutations. It has lower activity against wild type EGFR. And the most important thing, it crosses the intact blood-brain barrier as seen in preclinical models, and it works very nicely when CNS is involved. Next. Now coming to the FLORA trial, which is a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI as first-line treatment in patients with locally advanced or metastatic EGFR mutated NSCLC. Next. So this is the study design, where patients with locally advanced or metastatic NSCLC, and the key inclusion criteria must be 18 years or more, WHO performance status of 0 or 1 with the specified mutations, EGFR mutations, and a stable CNS metastasis was allowed. And they were randomized into 2 arms, osimertinib, where it was given at 80 mg per oral OD, and the EGFR TKI, which is the standard of care. Then the geftinib and allotinib TKIs were used, and the RECIST 1.1 assessment every 6 weeks was done until objective progressive disease. And one thing, the crossover was allowed. Patients with confirmed progressive disease were allowed to crossover and use osimertinib. The primary endpoints were PFS, and the secondary endpoints were objective response rate, duration of response, disease control rate, depth of response, overall survival, patient-reported outcomes, and safety. Next. In the FLORA trial, the baseline characteristics, as we can see, it was well balanced across the treatment arms. Next. Now coming to the efficacy part, the primary endpoint, which was PFS by investigator assessment, here we can see the median PFS in the osimertinib arm, it is 18.9 months versus 10.2 months in the standard of care arm, then that is geftinib and allotinib. and it has a hazard ratio of 0.46. That is, osimertinib reduces the risk of progression or death by 54% compared to the standard EGFR TKIs. And we can see the curves, they keep on separating, and it is from the very initial phase, say almost from the 1 month mark, they start separating. Next. Now coming to the efficacy, the PFS across the subgroups, we can see that a consistent benefit of osimertinib over standard EGFR TKIs with respect to PFS was seen across all predefined subgroups. Next. Now coming to the objective response rate, we can see the objective response rates. The response rates were higher in the osimertinib arm than the standard of care arm. And if you see the duration of response, the median duration of response in osimertinib arm, it was 17.2 months against 8.5 months in the standard of care arm. So the duration of response is almost 2 times as long in patient treated with osimertinib. Next. Coming to the FLORA OS, the final analysis, here we can see the final analysis of OS demonstrated a clinically meaningful and significant, statistically significant improvement with osimertinib versus EGFR TKI. And we can see that the osimertinib, the OS is 38.6 months, and EGFR TKI comparator OS, it was 31.8 months. Next. Coming to the adverse event summary, the median exposure of osimertinib, it was 20.7 months as against the EGFR TKI, where it was 11.5 months. And we can see here we can see both the adverse events, all grades and grades 3, 4 have been given. And the incidence of diarrhea, nail effects, dry skin, paronychia, stomatitis were almost equivalent, and acne and rashes were more common in the EGFR TKI comparator arm. We can see SGOT, SGPT elevation, transaminitis being a major culprit in the EGFR TKI comparator. Next. Now coming to the overview of adverse events and the safety analysis set, we can see if we see any adverse event, it was equivalent in both the arms. And if we consider grade 3, 4 adverse events, it was more in the standard of care arm, it was 44.8% versus 33.7%. And any adverse event leading to death, it was more in the EGFR comparator arm than the osimertinib. And similarly, if we see adverse event possibly causally related, then the adverse events were almost similar, and grade 3, 4 adverse events were very low in the osimertinib arm, it is 17.6% versus 28.2%. Next. So the FLORA study summary, osimertinib resulted in highly statistically significant and clinically meaningful improvement in PFS over the standard of care. The HR was 0.46, that is 54% reduction in risk of progression or death was seen relative to the standard of care. A significant and clinically meaningful improvement in CNS PFS was also seen. Final analysis of OS results showed promising survival trend favoring osimertinib versus standard of care. Now, comparable safety profile of osimertinib to standard of care, overall lower rates of grade 3, 4 adverse events and a lower discontinuation rate was seen with osimertinib. So, osimertinib is a new standard of care for first-line therapy in patients with EGFR mutated advanced NSCLC. Next. Now coming to the CNS efficacy, next slide. As we can see, CNS metastasis occur at higher rates among those harboring EGFR mutations compared with wild-type EGFR. So we can see in this chart that patients like brain mets at initial diagnosis, patients with EGFR mutation, it was seen in 19 to 24%, while in wild type, it was seen in only 11 to 13% of the cases. And during final follow-up, in the EGFR mutated arm, mutation, it was seen in 44%, and in wild type, it is seen in only 22% of the patients. Similarly, the leptomeningeal metastasis rates, it was higher in the mutated EGFR patients than the wild type EGFR patients. Next. The CNS activity, the PFS in patients with and without CNS metastasis at baseline. With CNS metastasis on the left-hand side, we can see the median PFS is 15.2 months versus 9.6 months in the standard of care. The HR being 0.47. And without CNS metastasis, if we see on the right side, the median PFS is 19.1 months in osimertinib arm versus 10.9 months in the standard of care. So osimertinib benefit was consistent in patients with and without CNS metastasis. Fewer CNS progression events were observed with osimertinib, which was only 6%, versus the EGFR TKIs, which was 15%. Next. The CNS activity, the CNS PFS in CNS full analysis set, it was seen the median CNS PFS in osimertinib arm, it is not reached versus 13.9 months in the standard of care arm. The hazard ratio is 0.48. Next. Now, let's try to compare the efficacies of osimertinib versus dacomitinib. We don't have any head-on-head trial, but we have two different trials. It won't be wise to compare directly, but in order to get what the situation is like, we can see both the two trials. Here for the PFS in the Archer 1050 trial, where dacomitinib was compared against geftinib, the median PFS was 14.7 versus 9.2 months. While in the Flora study, the median PFS, it is 18.9 versus EGFR TKI, it is 10.2 months. So the hazard ratio is 0.46 in the Flora study versus 0.59 in the Archer 1050 study. Next. The Archer 1050 OS was not statistically significant since the formal comparison of overall response rate was not statistically significant based on the study's hierarchical testing rules. So we can see the median OS, it was 34.1 in the dacomitinib arm versus geftinib, it was 27 months. Next. Now coming to the Flora trial, the first time on EGFR TKI has translated PFS to a significant OS benefit. It was never achieved in previous EGFR TKIs, but here we can see a median OS of 38.6 months versus 31.2 months. And if we see the 3-year OS, it is around 54% in the osimertinib arm versus 44%. That is a 10% benefit is seen. Next. Next slide. Now coming to the osimertinib versus afatinib. Similarly, we cannot have comparisons directly, but we can see the LuxLang 7 trial. Coming to the PFS of afatinib, the median PFS was 11 months versus 10.9 in the geftinib. So, and osimertinib has a median PFS of 18.9 months. So there were insufficient events to determine OS of afatinib at the time of analysis. Next slide. The phase 2B open-label dapatinib Lux Lung 7, the dapatinib compared with geftinib, we can see the co-primary endpoint of OS survival advantage was not seen. It was 27.9 versus 24.5 months. We can see the two survival curves almost going into each other. Next. Now coming to the LL7 OS for pre-specified subgroups of interest, exon 19 deletion and L858R showed similar OS trends. Median OS with afatinib versus geftinib in patients with exon 19 deletions, it is 30.7 versus 26.4 months. The hazard ratio was 0.83. And similarly, in patients with the L858R mutation, it was 25 versus 21.2 months. The HR being 0.9. Next. So coming to the safety profile comparison with other TKIs, we can see if we compare the three trials, Flora, Lux Lung 7 for afatinib and Archer 1050, which has dacomitinib, we can see all the side effects made with skin rash, paronychia, diarrhea, stomatitis. These were very much lesser in the osimertinib arm, which was very less, and the dose reduction required, it was in only 5.4% of the patients. In afatinib and dacomitinib, the side effects were higher and dose reductions were required in almost 50% of the patients. Next. So Flora study was also a sequencing study. The osimertinib versus comparative arm where sequencing was done, the first generation TKI was given first, and then the third generation TKI, when it progressed, was seen, and 47% crossover was seen. So first line osimertinib had better results compared to sequencing strategy. That is, in the comparative arm, when first generation TKI was followed by third generation TKI, the results were not that good comparable to osimertinib in the initial first line. Hence, the dilemma of sequencing is also resolved by the Flora study. Next. Now coming to the second line treatment eligible and predict. So what are the things? Like if we are taking say 100 patients, only 73 to 77%, that is 73 to 77% of EGFR mutated patients, they receive second line therapy. Others, that is almost 30 to 40% of the patients, they are not eligible for second line therapy because they either die during first line or receive only palliative care upon progression. So that is the reason we have 30% of patients who did not have the opportunity, who did not get the opportunity to receive any second line therapy. Also, we cannot predict like which patients will develop T790M resistance. So if we are not giving osimertinib initially, we are losing on these patients. Next. Hence, it is important to start it initially. The use of osimertinib as second-line therapy in Flora was consistent with expected rate in clinical practice. Like when we see the patient disposition in comparator arm, 30% of the patients in comparator arm could not receive, as I have already told, they could not receive a second-line therapy, which was consistent with the attrition rate seen in real-world studies and other clinical trials. Now, in the second line therapy in the comparator arm, 47% of patients in comparator arm who did receive second line therapy received osimertinib consistent with expected rate of T790M. So, in total, 31% of all patients in the comparator arm received osimertinib as second line treatment. Next. So, these the real world evidence which shows that in clinical practice, approximately 1/3 of patients or fewer receive second line osimertinib. And this is the reason we if our patient is affordable, we should start the patient on osimertinib itself in the first line. Next. Now coming to the NCCN guidelines for therapy of EGFR mutation positive NSCLC, osimertinib is the preferred category 1 drug to go to if we have EGFR mutations. And the other recommendations, as we can see, we have erlotinib, afatinib, geftinib, dacomitinib, and options of combining erlotinib with ramucirumab, erlotinib with bevacizumab. We can always go through this chart. Osimertinib so has been given a preferred recommendation in first line treatment. Next. So coming to the conclusion, for the first time in the evolution of EGFR TKIs, which we have never seen in other EGFR TKIs, osimertinib has translated the PFS benefit to a significant OS benefit. In other TKIs, we had the PFS benefit only. Osimertinib has the median PFS of 18.9 months and median OS of 38.6 months, which is significantly higher than the first and second generation EGFR TKIs. Osimertinib has shown efficacy in patients with CNS metastasis. Fewer CNS progression events were observed with osimertinib, which is 6% compared to the standard of care then EGFR TKIs, which is 15%. Fewer and less severe adverse events gives osimertinib a better safety profile than the other EGFR TKIs. Osimertinib is the new standard of care for first-line therapy in patients with EGFR mutation advanced non-small cell lung cancers. Next. Thank you, and thank you, sir, for giving me this opportunity. Thank you again.
Thank you, Dr. Rajiv. That was a wonderful presentation. So
Thank you,
clearly translating EGFR mutation into incorporating into practice and the benefit translating into OSIS. That is a wonderful success story. And showing us the comparison where the osimertinib stands as compared to dacomitinib and the afatinib in different studies, and third generation versus first generation, and benefit in CNS disease also. So that is very encouraging to see and know. So we have next speaker. Next speaker is Dr. Chandrani Malik. He's a medical oncologist from Calcutta. So she will be speaking on real world evidence of osimertinib in treatment of EGFR mutated non-small cell lung cancer. So we know trials are done in exclusive setting. So over to you, Dr. Chandrani, for your presentation, please.
Am I audible?
Audible, ma'am.
Yeah. Am I audible?
Yes, Dr. Chandrani, you are audible.
Okay. Can you organize? Can you please share my slides? So today we are going to speak about real world evidence. So we have discussed about the osimertinib and its trials which have proved its efficacy. Next slide. So to start with, we all know that for all patients with EGFR mutations, there has been PFS benefit with EGFR TKIs, and as we have discussed, osimertinib has been the most potent third generation EGFR TKI, which has shown improvement in the median PFS and OS, and this has been approved through the FLORA trial. Next trial. Next slide. So this was the final overall survival analysis of the FLORA trial, which has been discussed in details by Dr. Rajiv. Next slide. It was a double-blind study design where stratification was done based on the inclusion criteria mentioned here into two arms, osimertinib 80 milligram per oral daily compared to the comparator EGFR TKI arm, gefitinib or erlotinib, and then OS was seen as a secondary endpoint. Next slide. These are the baseline characteristics which have been discussed. Next slide. So on the primary analysis, we can see here clearly, and we have just discussed that there has been significant overall benefit in the progression survival. Next slide. So if we see the overall survival also, you can see that there has been significant improvement in the median OS of 38.6 months with osimertinib. Next slide. On conclusion, the final OS analysis of this FLORA trial reinforced that osimertinib was the standard of care for first-line treatment of patients of EGFR mutated advanced non-small cell lung cancer with favorable, consistent toxicity profile. Next slide. These are the NCCN guidelines, uh, which have actually shown as the osimertinib as the category 1 recommendation for this subgroup of patients. Next slide. So now we are going to discuss about the real world evidence of osimertinib, what we have seen in our clinical practice following the FLORA trial results. So first we have the flower study. Next slide. Next slide. So in as we all know about osimertinib, I'll not go into the details of its benefit of OS and PFS. So why we have done this real world data? Because real world data are always helpful as useful tools to actually assess the insights into what we do routinely in our oncology practice post the marketing setting. Next slide. So the key features, the baseline features in this study was the age was the median age was 68 years. Brain metastasis was present in about 30 counted numbers in the study, and most patients were stage 4B. Next slide. The inclusion criteria was age more than 18 years with histologically proven non-small cell lung cancer with EGFR mutation in exon 1821 and locally advanced recurrent or metastatic setting, and eligible for first-line treatment with the third generation TKI osimertinib. Next slide. Now, coming to study endpoints, apart from the secondary endpoints of the median OS, the median PFS, or overall response rate, disease control rate, what was very importantly highlighted in this study was the median time to treatment discontinuation. So that was measured from the starting of osimertinib to the discontinuation. And why was it done? It was actually an exploratory approach to in this pragmatic real world endpoint to actually see the effectiveness of the anti-cancer therapy in this setting, and reflected the common practice which we when we continue treatment beyond resist progression, so which we actually justified by our the type of the biology of the tumor in which say oligo progression occurs, and when we continue the treatment. So what our observations are, so that has been actually studied in this particular study. Next slide. Go to the next slide. There's a repetition. So if we see this these curves, we can see here the median time to treatment duration. So in the first one, we can see it was 25.3 months. In the next one, if we classify the patients into patients who had symptoms versus no symptoms, so patients who had symptoms, their prognosis was worse. It was about 18 months compared to the patients who had no symptoms. And for people who had metastatic sites more than 3, the median the time to discontinuation about 21 months. So these were the criteria in the study to see which patients actually fared better with the use of the drug with these baseline characteristics. Next slide. So we can see in this that with the patients with poor PS, with comorbidities, with rare mutations, and active brain mets were all included in this study, which were excluded previously in the FLORA trial. The outcomes were very similar to the published data, so it added to the efficacy of the drug. And there was no difference in the OS or the PFS data that was collected previously. Next slide. Okay, so at the last, what we studied is what I was telling about the time to treatment discontinuation. So that was actually studied as a very suitable endpoint to see the treatment outcomes in our real world trials. It was seen that it was about 26 months longer than the post progression outcome analysis of the FLORA trial, which was about 20 months, which was probably due to study population which was unfit for further treatment, or different therapy was given for the oligoprogressive diseases. It was better TTD was observed with patients who had less than 3 sites or isolated progression compared to other progressions. Next slide. You can skip to the next one. So we can see in this data in the tables that the poor treatment outcome was seen for patients who had brain mets and presence of symptoms and more than 3 metastatic sites at diagnosis. So it which suggested tumor load as a negative prognostic factor in this case. Next slide. So after median follow-up of about 12.3 months, the median PFS was about almost same 18.9 months, and the OS was not reached at the time of the cutoff. And we can see in this chart that in about 92 means 73% patients there was partial response. Next slide. So if you see the PFS now, so median PFS with or without brain mets. So with brain mets it was a bit worse at 13.3 months, and for patients with symptoms it was about 15.5 months compared to patients who had no symptoms. Next slide. Next one. Next line. So on the multivariate analysis, no, previous one. So on the multivariate analysis, in the lower part of the slide, we can see longer PFS was noticed actually for absence of brain mets, prolonged PFS, and prolonged OS was also noticed for patients without symptoms at diagnosis, and the time treatment discontinuation about 9 months or more was significantly higher and associated with better OS. So that is what our actual achievement was in the study. Next slide. Okay, so the next secondary endpoint was a real-world diagnostic therapeutic pathway. So this is a very essential element of evidence-based medicine and helps in our clinical decision making. So the molecular analysis here was performed in about 13 samples, where druggables or resistant mechanisms were included in the following types: in the MET amplification, or MET EGFR amplification, or the HER2 amplifications. Next slide. Next slide. Okay, you can complete the whole slide. So in the safety data and conclusion, we can see here that venous thromboembolism was the most common, and 110, so 87% patients experienced adverse effects, among which only 33% was about grade 3 to 4. Scroll down for further, there are a few lines more. Yeah, so also seen that there was no difference in the rates of the venous thromboembolism according to the age, the PS, the comorbidity, or the tumor load. Next slide. So what we have proven from this is that there was no difference in survival observed according to the age, the comorbidity, and the type of the EGFR mutation, and osimertinib has confirmed its effectiveness and safety in the real world scenario. Next slide. Next, coming to the next study. So here the osimertinib was seen as a first-line treatment for advanced EGFR positive NSCLC in real world settings, OSI fact study. Next slide. So here again, we can see here that in the current study, they investigated the difference in the efficacy with the patient background and the safety of first-line osimertinib in real-world scenario. Next slide. So inclusion criteria: advanced EGFR positive non-small cell lung cancer with osimertinib as the initial treatment, with the other exclusion criteria. Next slide. There's one more chart. So in the baseline characteristics here, we can see that the different patients. So currently in this study, there were more adenocarcinomas, and female patients were more in number with better ECOG status, and PDL1 status. Maximum number of patients were in 1 to 49%, with brain metastasis mostly absent in this case. Next slide. So second study endpoints, the primary endpoint here was PFS, and the rest all were the secondary endpoints like OS or time to treatment failure, the complete, the objective responses, or the disease control rate. Next slide. What we have seen here, the median PFS was happened in 182 patients of the 538 patients, and it was about 20.5 months. And there were parameters that were associated with better PFS. So what were they were associated? Say male gender, malignant effusions, liver metastasis, or advanced unresectable cases, where obviously there was a negative association with the PFS. And with respect to the PDL1 expression, obviously we can see here that with TPS score also there was a relation with the PFS benefit. So with TPS of about 50%, it was 11 months, whereas with less than 49%, it was 14.7 months. Next slide. So this is the chart which showed the efficacy analysis. Next slide. Patients who had undergone treatment discontinuation. So who had undergone treatment discontinuation, the maximum number of patients was about 44% cases who actually underwent due to disease progression. Followed by that, we have 25% patients who actually had due to pneumonitis, and rest were very negligible for mostly disease progression followed by pneumonitis. That were patients who had discontinued the treatment. Next slide. Safety profile, we know it was well tolerable, excepting pneumonitis, which happened mostly in 12.8% patients in all grades. Other grades were much lesser. Next slide. So in conclusion, what we can state here that in this study we found that the overall response rate here was good. It was about 76%. Disease control rate was 94%. PFS was better with osimertinib than the other conventional EGFR TKIs. Median TTF was 19 months. There was a better adverse effect profile. So, in conclusion, PFS after first-line osimertinib treatment was favorable in real-world practice, as proven in the previous trial, and discontinuation rates were lesser, especially when pneumonitis, which required further investigation. Next slide. Now coming to the last real world study. Next slide. So this study actually reported the demographic and the clinical characteristics, where they studied the real world time to treatment discontinuation and real world time to next treatment or death. So that's what those parameters they have studied to see which patients benefited from osimertinib. Next slide. So this was actually a global observational prospective study which actually happened in continents of US, Europe and Asia and were maintained through a registry and electronic health record data. So during this study period, actually they were happening in mostly in US, they were happening in the US cancer clinics and for this sub-analysis data were collected through June 30, so there are a deadline of June 30, 2020. The study was ongoing and the follow-up period planned till June 2023. Inclusion criteria were same as other studies. Next slide. So here the patient identification start date was in April 1st, 2018 and patient identification window happened at March 31st, 2020. And then the follow-up continued and the interim analysis cutoff date was June 30, 2020 and continued to 2023. Next slide. So what was the assessment and the analysis they were done? So baseline clinical and demographic characteristics were summarized using descriptive statistics. Kaplan-Meier curves were generated for the real world time to treatment discontinuation and the time to next treatment or death. So there were the first was the real world time to treatment discontinuation defined as the time from the index date until the start of next systemic therapy or death in the absence of the next systemic therapy. And the next was real time time to next treatment or death, which was the index date when until the earliest end of the osimertinib therapy associated with the discontinuation on or prior to the end of first line therapy. So those were the two parameters which were studied and Cox hazard models were used. Next slide. So these are the socio-demographic characteristics which were actually imbibed in the study. Next slide. Clinical characteristics wise, we can see here most patients were in stage 4 with mostly non-squamous variety with good performance status. Lesser patients had history of smoking and patients with good Charlson comorbidity score index being in good numbers and metastatic sites were also seen counted. So about 46% were only 0 to 1 sites of metastasis. Liver metastasis mostly did not have, and even brain metastases also did not were not taken mostly. There were about 33% of patients who had brain metastasis. Next slide. So mostly the mutations that were taken, EGFR mutation positive, common mutations taken were about 85% and the rest were non-uncommon mutations. Next slide. So at the analysis, at the interim analysis, what did we see? That about 58% patients remained on the first line therapy or were lost to follow-up. 18% patients received the second line treatment. About 18% patients died while on the first line treatment and 4% only discontinued the first line treatment. Next slide. So median follow-up of this study was about 9.6 months and again we studied those two parameters. We saw that the median real world time to next treatment or death was about 17.9 months. Next slide. And what we also saw in the multivariate analysis that there are few variables which are significantly associated with these parameters. They were the stage at initial diagnosis, the smoking status, the comorbidity index, EGFR mutation time, and number of metastasis sites if more than 4. Next slide. For the other parameter, which was the real world time to treatment discontinuation, that was the median value was about 17 months. Next slide. Next slide. So what was the actual take home message from this? That this study actually gave proper insights into the use of first-line osimertinib in these advanced EGFR mutant patients based on the data analysis, and the two interim markers which were studied actually resulted in better effectiveness of osimertinib in the real-world setting. However, longer treatment outcomes need to be evaluated, and we need to do further more real-world studies to confirm these parameters better. So I will end my presentation here. Thank you.
Thank you, Dr. Chandrani. That was a wonderful presentation and to what the real world data looks like. So next, I will be talking about reinventing the uh, therapy in the EGFR mutation in early lung cancer patients. So just give me 1 minute to share my slides. So just uh, so I think my slides are visible.
Sir, not now, sir.
Not
Yeah, it's
now.
visible now.
Oh, it's visible. So, good
Yes.
evening, everyone. So, thank you, everyone, for this is the last talk. I'll not keep you waiting much. So, I'll be talking after the EGFR mutation, the data which we have in metastatic setting. Now, reinventing the adjuvant therapy in EGFR mutation, early lung cancer. Why is it important? So we know even the survival outcomes in the resectable non-small cell lung cancer needs to be improved. So if we look at the global 5-year data, survival data from stage 1B to stage 3A. So in stage 1B, it is 65 to 75%, which decreases to about 30 to 45%. About 50% fall is there as the stage increases. So definitely there is unmet need there to improve the outcomes, even in the resectable stage where we think we have cured the patient. So that's why as of today, there is recommendation to do EGFR and PDL1 mutations early in the course of the treatment also. So if we look at the current testing and the treatment pattern, so we know the prevalence of EGFR mutations in the resected stage 1 to 3 non-small cell non-squamous lung cancer. It is in about 50% of the patient the mutation is present, and out of which the 19del is the most common, followed by L858R. So whether we can use these mutations which are present in the adjuvant setting, that is the issue. So if we look at the current treatment testing and the treatment pattern, we will be surprised to know that about 73% of the patient underwent surgical resection only, and about 46.3% received adjuvant systemic therapy. So less than 50% of the patient receiving the adjuvant systemic therapy. And if we look at the subset analysis, like the stage wise, so in the earlier stages, the use of adjuvant systemic therapy was much lesser as compared to those in the advanced stages. So we know after initial treatment, more than half of patients with resectable non-small cell lung cancer, they experience recurrence within the 5 years. So it means there is a heavy burden which will who will recur, and there is a lot of scope of improvement. So what can be done for these patients? So we know if we give adjuvant chemotherapy, which was proved in Anita study, we could salvage another 5% of the patients after 5 years. So reducing the risk of recurrence by another 5%. Still, there is unmet need. So in those settings, we know we have EGFR mutation, which is present in these patients. So in adjuvant study setting, the studies have been done earlier also. Like the Select, Radiant, and Ivan, all these studies, they used first generation erlotinib, and the adjuvant and CTONG 1104 and BR.19, it looked at gefitinib. But none of the studies showed OS benefit. All had shown clinically meaningful benefit and PFS advantage. So, whatever current evidence we have, it has shown there is DFS advantage. There was 48% reduction in risk of disease recurrence, which was shown in different studies across. So, these data have not resulted in change to clinical practice. Why? One, maybe the trials to date have been limited by design and size and other factors. It has these studies that they did not show any OS benefit, and they were unclear if the adjuvant EGFR TKI therapy results in cure or delays in recurrence. And there was no definitive evidence of appropriate sequencing of drugs or duration of the treatment. So, to address this, the ADORA study was done, which included patients who were completely resected. They had stage 1B, 2, 3A non small cell lung cancer with or without adjuvant chemotherapy, and they all had exon 19 del or L858R mutation. And they were stratified according to the stage, EGFR mutation status, whether they have del 19 deletion or L858R mutation, and Asian versus non-Asians. So post-treatment, adjuvant treatment, they were randomized to receive osimertinib or placebo, and the treatment duration was continued for 3 years, and the disease treatment was continued till the disease recurred, or there was treatment completion, or there was discontinuation because of any reason. And the key endpoints or the primary DFS, primary endpoint was the DFS, and the key secondary endpoint was DFS in overall population. So if we look at the ADORA trial results, clearly the ADORA showed there was significantly improved DFS, which was there in the primary as well as in the overall population. If we look at the hazard ratio, definitely the benefit was there in stage 2 to 3A patients in and the hazard ratio was 0.23, and in the overall population also there was benefit 0.27, clearly showing there was improvement in the patients who had received the osimertinib in the adjuvant setting. So the important another unmet need is the patients, they have usually brain mets. The CNN mets, we know they it confers poor prognosis. Again, osimertinib being a third generation, it has a very good blood-brain barrier penetration is there, so it showed improved CNS efficacy. So again, Adura updated CNS DFS analysis, which was published in January 2023. It showed though the in both the arms, the median OS DFS was not reached. The hazard ratio was 0.24, favoring the osimertinib arm. So again, if we look at the side effect and the safety profile, though obviously there were more grade 3 side effects as compared to the placebo arm, and it did lead to more discontinuations, but there were no grade 5, that is, there was no death in either arm. And there were no new safety signals. And with our routine use, we know how to handle the medicine. And usually, our learning curve we have achieved. So, in summary, the key take points from this presentation. So, in order to improve survival, we need to put more efforts to identify lung cancer early. Again, we should not miss the opportunity to test for actionable mutation, which was shown by Dr. Paulomi in her first presentation. So this is now applicable to the early lung cancer patients also. And again, the collaboration is the key to improve the survival. And patient may have many options to increase the survival probability. And we should know all the options, and which can be done by doing molecular testing. And in metastatic setting, we had osimertinib, which had shown unprecedented benefit. In early lung cancer, we have ADURA. The data gives a probability of cancer patients to remain cancer free along with survival benefit. So, being cancer free is the goal of the treatment. For us also, we are happy if our patient remains in remission. With this, I'll say thank you very much. So, again, to conclude, I thank all the eminent speakers of today, and I thank our academic partners who has helped us in discussing this important aspects of lung cancer. With this, I'll hand over back to you. Thank you very much and good night.
Thank you, sir. Thank you.
Thank you, Dr. Sumit, Dr. Paulini ma'am, Dr. Rajiv sir, and Dr. Chandrani. Thank you for participating for this virtual webinar. So, thank you so much for everyone.
Thank you. Thank you.